Well, good morning, everyone. My name is Abra Lyons-Warren. I'm the Senior Program and Policy Manager at the Council of Large Public Housing Authorities. For those of you who joined us yesterday, welcome back. For those of you who are joining us for the first time, good morning and welcome. Steve, would you like to introduce yourself?
Sure. Good morning. A lot of friendly faces, familiar faces again. Welcome to the second day of the Housing Summit. I'm Steve Lucas, the Health Research and Policy Manager here at CLPHA. We're really thrilled to have a great plenary panel this morning and another round of great sessions this afternoon. I think just on a housekeeping note, I think we've figured out the right way to do the breakout sessions with the links. You should have been admitted through the Zoom room lobby that we've set up or through the agenda. So hopefully that was a little smoother than yesterday, but please give us any feedback you have about the virtual experience, and we'd love to know it for future events. With that, I'll hand it back over to you, Abra.
Yeah, I think hopefully everyone is feeling a little bit more comfortable with Zoom today, but if not, we do have that help desk number listed on the screen that you can call if you need any assistance, or drop us a question in the chat box. You should also feel free to put any other questions that you might have in that chat box, or use some of the virtual reactions if you'd like to give a thumbs up or applaud anything that you're hearing this morning. So I think with that, oh, I'm not sure she's quite ready, so we'll pause for a moment. But yeah, I think Steve and I were very energized and appreciative from some of the comments and feedback that we got yesterday. We always want it to be a meaningful event for all of you. So please continue to let us know if there are things that we can be doing to make the experience better or more useful for you. Okay, great. So I think with that, it's my pleasure to introduce Jeannie Fakata-Selassie. She is the Project Director of Funders for Housing and Opportunity, and CLPHA has been so pleased to work with them for our Housing Is initiative. Jeannie?
Thank you, Avra. And thank you to CLPHA for the opportunity to be together at a point in our nation's history that feels very significant. I'm Jeannie Fakata-Selassie with Funders for Housing and Opportunity. We're a national funder collaborative, and we, like you, understand that where a person lives matters. It determines the opportunities people have in all aspects of their life: mental and physical health, academic achievement, economic mobility. And like you, we understand that people in communities of color have been disproportionately and systemically left behind, and that this disparity can be traced to deeply rooted systems and practices of racial bias, discrimination, and segregation that greatly limit housing options and therefore life opportunities for Native persons and people of color. And the layered public health and racial equity crises that we're experiencing today are not moments in time, but rather they're the product of decisions upon decisions that were made where equity was not centered. What we're experiencing is not a failure of one siloed system. It's not just a reflection of the housing system or just the education system or health or criminal justice systems, but it's the chronic failure of multiple systems over a sustained period of time, which is why the cross-sector work that you're doing is such a bright spot and is so very important. And I really commend CLPHA for having the foresight to provide a forum that elevates what works and helps all of us make connections so that practices that center people and improve the systems that surround them can be adapted and replicated. I'd like to close with a thought from our friends at Race Forward, who talk about equity happening at the moment of choice. I'd like to invite all of us to take time right now to recognize the hundreds of choices we make every day, decisions both big and small. And I'm going to pause for a moment now so you can bring to mind and maybe write down a few of those choice points and to ask yourself, do any of those decisions have equity implications? And if not, to think again. And if so, to think about what you might do differently the next time you're confronted with that choice. I'm just going to pause now for a few minutes so we can each bring to mind a few of the choice points that we have authority or control over. So decisions like what organizations to partner with, who we invite on our strategic planning committees or on our boards, where we bank, what organizations we invite to respond to our RFPs, or even who we call on first in meetings and who gets the last word, where we volunteer our time, how we answer all those questions our children are asking. All of these choices provide us with the opportunity to do better and to break down and reconstruct our muscle memory, to commit to new ways of acting and thinking that can point us toward a more equitable future, one choice point at a time. Thank you.
Thank you so much, Jeannie, for those encouraging words. It's really great. You're obviously at the helm of a lot of philanthropic decisions, and so it's really fantastic to hear the thinking and intent behind some of those investments. So thank you so much for the support from FHO and from you to our organization. We're looking forward to a really fantastic morning. I am going to turn it over to Steve to introduce our next speaker.
Great. So I have the pleasure of introducing one of our esteemed members, and also who will then introduce our keynote speaker this morning. So Michael Liu from the Miami-Dade County Housing and Development Department is here from the Miami area to introduce Congresswoman Donna Shalala.
Thank you, Steve. It's great to be here. It's a real honor to introduce someone who is a pioneering Peace Corps volunteer, an academician, an educator, someone who is able to develop policy even in 10 floors of basement, as we know the HUD building is, former cabinet secretary, head of 3 fine universities like the U, as noted on Monday Night Football, a Hauser, and now a member of Congress. What hasn't she done? What sets her apart from so many in the Beltway is that she has taken ideas and policies and actually applied them in practice as a leader, as a changing agent. She has had the opportunity and the challenge to see firsthand how her decisions actually impact the lives of real people. And this is why I have so much respect for her. She's not like the talking heads, career politician wannabes, or think tank gurus who have never managed anything in their lives. But boy, they still have a lot to say, don't they? So some time ago, I decided to be very selective as to what I would read and who I would listen to in regard to current events, political thought, and professional growth. And one of those people, one of those persons, is our keynote speaker. Smart, seasoned, someone who has managed big budgets, big payrolls, diverse workforces, big egos, lots of bricks and mortar. In other words, large, complex organizations. Hey, sounds like she would make a great CEO of a large PHA. CLPHA members and friends, without further ado, we welcome, and I'm honored again, the inimitable and indomitable Congresswoman Donna Shalala of South Florida.
Thank you, Michael. I have tremendous respect for your leadership, both at the national level and here in Miami-Dade County. You've done incredible things. And thank you all for inviting me to speak during this year's summit. You know, Winston Churchill once said, if you're going through hell, just keep going. That's been my philosophy of life. People say to me, well, what if you're stopped over here? I said, I just keep going. There's always something to do going in another direction. This is the nation's, I want to recognize the incredible work of the Consul. And you have really made a difference from encouraging us to include more housing assistance in the economic relief packages, to holding the administration accountable for cruel proposals that would force families to decide between a roof or meals for their children. You've been at the forefront of relief efforts that that make a difference for low and moderate income people, as you're really This is the nation's foremost convention of leaders from the affordable housing, health, and economic education sectors. I love this virtual summit. I spend a lot of time on Zoom these days. We just can get things done, and it doesn't make any difference what the technology is. Improving health, education, and housing and life outcomes for low and moderate income people have really been my life's work. I entered public service, as Michael indicated, as a Peace Corps volunteer, but my first paid government job was as the Assistant Secretary for Policy at HUD when I was very, very young in the Carter administration. And that's where I really learned about public housing and about affordable housing issues and how difficult it was to put those programs together and to give people a real opportunity. Wherever I have been on this earth, there has been no difference in what families want. Wherever I have been, what they wanted was to provide their children with safe homes and full futures. People here at home and around the world want exactly the same thing: a better life for their children, a safe and affordable place to call home, and the knowledge that in difficult times they'll be supported and not forgotten. And that's what we need to do today. That's very much our task today. We want to lift families out of poverty. We want to work to preserve and improve public and affordable housing. We have to chart new courses as far as I'm concerned. This summit gives us the opportunity to learn from one another, to share with one another, and to address our common experiences and concerns. In charting a new course, that includes some old ideas that we were never fully able to execute. And that is integrating education and childcare and healthcare and housing as interconnected solutions. And if we can do this, we can address the most compelling challenges facing low-income families. Having access to safe, quality, affordable housing and the necessary support to uphold that housing is without a doubt one of the most basic and powerful social factors of health. We talk about the social determinants of health. Housing is such a critical part of that. This is especially true for families trapped in cycles of crisis and housing instability due to extreme poverty, violence, mental illness, or addiction. I'm reminded that just 50 years ago, Congress passed one of the crowning achievements of the civil rights era, the Fair Housing Act. The Fair Housing Act banned racial discrimination in real estate and required the government to take steps to proactively integrate neighborhoods. While the landmark legislation brought desperately needed federal action to address the widespread housing segregation that existed in this country, many communities continue to experience housing insecurity. Today, for every 100 low-income families, there exist only 35 homes affordable and available to them. We've left millions vulnerable to eviction or homelessness, and this pandemic, with its economic consequences, has made that even worse. The devastating effects are felt most profoundly within communities of color. We know that. The disparities for Black families, for Hispanic families in my community are readily apparent in education, in housing, and in healthcare. In 2019, more than half of Black and Latino renter households were cost burdened. They were spending more than 30% of their incomes on housing expenses. As the previous speaker said, where we live has a profound impact on the opportunities we have in life. Where we live has a profound impact on the opportunities we have in life. It's an honor to join all of you at this summit and to work together to build better lives for our families and for our children. Thank you very much, and I look forward to the panel. Thank you for inviting me.
So something when I was researching before your keynote address, something that you said resonated, and we got a question about sort of shifting paradigms of like large institutions, and something that you've talked about in some of your public remarks before is you like running big systems. You said that today as well. How do you change from an institutional perspective, whether it's this cross-sector approach, integrating health into housing conversations, education into health conversations, and big systems, lots of people, and most notably, large bureaucracies? How can you move the needle as a leader to make those connections? And maybe separately and operationally, how do you bridge those gaps, break down those silos? That's a huge focus of this conference.
My experience is that you have to build teams. When I first arrived at HHS, they had an awards ceremony, and all the awards were for individuals. By the time I left, all the awards were given to groups of people who had solved problems. And when we surveyed our employees, they said the best experiences of their careers had been as part of teams solving problems across the agency. So we introduced healthcare into Head Start, for example, which required putting the Head Start people together with the healthcare people, which were two completely different agencies in the department, but they thought through. And by the way, we put people on the panel that actually had young children or had experience personally with Head Start. So that's one thing. The other thing is I always did was my policy table was diverse in terms of age and background. So there were people in my policy table, and it was a big policy table, people that made the major decisions for the department that had grown up in abject poverty. One of my senior people had rickets as a child. So I wanted people at the table for that department who had grown up in different circumstances. If all you do is hire people with Ivy League degrees that grew up in upper income families, you cannot make sensitive policy when you're dealing with low and moderate income people and their experiences. So when I talk about diversity, I talk as much about economic diversity as I do racial, religion, and all the other things that people talk about. And we had the leader, one of our leaders, top deputies, was totally disabled. He actually used a computer to speak, and he was totally integrated into the policy table. He taught me a lot about people that were disabled at every level of decisions that we were making, and everybody got to sit around the table on every issue, whether or not it was their expertise, because you never knew when you got an insight. So I broke down the department by making sure the top leadership were experts in their field. Unlike many presidential cabinet levels, I did not appoint a slew of people from the campaign who were generalists. I actually hired people for the agencies that were experts in the area, but had real experience. The person that ran Head Start, for example, ran a Head Start program. In fact, she was running the Washington, D.C. program when I hired her away, but she had a Head Start center herself. And in every agency, I hired people that would be respected by the civil servants. And that made a big difference, but integrating them and making sure they had different backgrounds has been very important in my career. And that's what I mean by understanding people's lives. I walked, 6 months ago, I made a big speech at a healthcare finance meeting. There were 1,000 people in the room, and I walked in, and the first thing I said to everybody was, how many people knew what the healthcare situation was of the waiters that were serving them right now? Not one person had asked. I ask. I can tell you every person that provided me with a service over a long number of years, whether it's my dentist or the dry cleaner, what their health care situation is. And because you have to understand what's really going on out there. And that's been the secret of my success in getting things done. I'm sorry, it's a long answer, but it's a different.
It's a complicated question, so I appreciate that. So I will just say I think just an announcement for the group, we've decided to close the waiting room so we don't have any more Zoom bombers. And also we will have to unmute anybody who's speaking today. So for any of our speakers, just know we'll unmute you. So Congresswoman, we have one more question for you, and then I'm so grateful you're going to join us for our next panel. And so I'll introduce that after. But the question we have is from someone at Seattle School District who's asking, how can we use, and thinking of big systems and lots of big budgets, how can we use housing resources to correct historical wrongdoings that oppress people of color and deny them for generations? And she references the book Color of Law, which looked at redlining and the history of residential segregation. So that question, about how do we use sort of the full heft of resources to correct those injustices?
The protesters today in almost every community, and I was out with them. Many of them were young, and I was very pleased that it was people from different backgrounds that were marching together. I wish they weren't so close together because I'm concerned about a spike in COVID-19, but at least they were outdoors. Housing can be a vehicle for providing opportunity, but unless those other opportunities are there, unless we have a supportive school system, unless healthcare is available for the people that live in public housing, unless they have access to transportation to get to jobs, unless they have high quality childcare so that they can get to jobs. I'm very concerned about the childcare system, as my colleagues are around the country, because often childcare centers in urban areas are in relatively small spaces. And we've got a real challenge. And by the way, when you're dealing with little kids, telling them about social distancing doesn't make any sense to them. Doesn't make any sense. And in my district, in Miami-Dade, Michael will tell you, we make our money out of crowds. So these are big challenges. Housing can be a key vehicle in which everything else has to be supportive of the people that live in housing. Housing alone can't make a difference. It's all the other things, all the other connections that housing makes for people. Once you're secure in a safe home, then your ability to reach out and for us to reach you to support you is very important.
Great. Well, thank you so much, Congresswoman, for your remarks and answering those questions. So we're going to transition next to our plenary panel, which the Congresswoman will be joining. I am pleased to introduce the panelists who are joining us. First, Andy McMahon from UnitedHealthcare Community and State. This is UHC's Medicaid practice. Andy is the Vice President of Health and Human Services Policy at UHC Community and State. Our next panelist, Pilar Sanchez. Pilar is the Vice President for the Housing Authority of the City of Austin, where she's been for 20 years. In this role, she oversees all of HACA's residential programming and workforce development, youth education, digital inclusion, and the health and wellness program. And finally, George Jones, who's the CEO of Bread for the City, which is a federally qualified health center here in Washington, D.C. George has, in addition to his work at Bread for the City, has served as chairman of the DC Board of DC Primary Care Association, a nonprofit which advocates for the expansion of healthcare access and the reduction of healthcare disparities among low-income residents in DC. With that, I'm going to hand it over to Andy McMahon, who will be moderating this panel. Andy, I need to unmute you, so I'm going to spotlight your video. There we go.
All right, great. The screen says I'm unmuted, so great. So thank you, Steve, and thanks to CLPHA and everyone for joining today. And I want to start, first of all, Representative Shalala, with an enormous note of gratitude and thanks for your decades of servant leadership and commitment to serving underserved and oppressed populations. Just to say, kind of personally, and I think for everyone, that you are kind of a guiding light for us. So really appreciate your remarks and your willingness to join us for this conversation as well. So much appreciated. And I also need to thank you, I think, because you did my job better for me than I could ever do in 100 years in terms of setting the table for this conversation about cross-sector partnerships. You know, I think it probably
Andy,
took
I did even better than that because I was on the United Health Board when we decided to go into the Medicaid,
That's great. Thank you. That is wonderful. Thank you. You know, and so I think you know, this plenary conversation is really thinking about how we put into action and into practice what Representative Shalala talked about. I think I jotted down the term interconnectedness, integration, and all the terms like that multiple times. And we'll just say that that is absolutely the key to what we're doing. And it may have taken managed care too long. I'm sure it did to fully know that housing is healthcare. But you can be assured that everyone in UnitedHealthcare sure as heck knows that now. And quite honestly, though, my job and the task at hand is then, so what? What do we do about that, right? So if we know housing is healthcare, what do we do about that to better serve people on our Medicaid programs, but low-income and extremely low-income folks all across the country? And so I'm delighted to have my panelists today, but I think, you know, we are really trying, we have been working with CLPHA and 6 different public housing agencies where we've created formal partnerships and have figured out how do we collaborate to better serve their residents and our members. And in particular, in expansion states, there's an enormous overlap between the two. In just Akron, Ohio itself, we have more than 7,000 of our UnitedHealthcare Medicaid members who are living in Akron publicly assisted housing. Until a year, 18 months ago, we had never talked to each other, right? That is not the best way to serve our members and their residents. And so we're figuring out through data analytics and other things, how do we then operationalize those partnerships, right? How do we partner as an MCO? How do we bring in our network of providers? I would say in particular, our federally qualified health centers that are really the safety net in the front line for almost all of our Medicaid members. How do we actually operationalize and create those partnerships and create that integration that the representative spoke about to improve the lives and improve the health outcomes for CLPHA residents and for our members and other MCOs members. So with that, I think I am going to start with the first question for Hilara and George. And I think, you know, we are living certainly in unprecedented times in terms of COVID-19 and the current unrest, some of which we, you know, even just experienced here a bit ago. I'm wondering if you guys could each just share a few words about kind of how you're thinking about the integration of healthcare and housing and human services, and kind of, you know, how you may or may not be thinking about that differently during these times. So, Pilar, why don't we start with you? Technical difficulties. George, are you perhaps on the line?
I am on the line. Have I been unmuted?
Yes, you have, George. I can hear you. Please go ahead.
Right. Right. Yeah. So I think it's a great question. This is, you know, I've been, like so many people, I've been thinking about this moment that we're in time. And this is the moment. I mean, maybe every 50 or 100 years or so in this country, there's a moment when we can move forward exponentially with the advances in social justice, racial justice. And I think we're in that moment right now. And I agree with one of the premises of this conference. Sorry about that. hold on. I agree with one of the premises of this conference, which is housing is fundamental. Housing is health. I love that expression. And I think that we need to walk through this door of opportunity right now and commit to housing as a right for everyone in this country. And one of the premises I think I wanted to sort of impart is that, history has taught us, particularly the sort of racial justice history has taught us that when people of color, when Black people in particular, realize advances because of public policy commitment and change and advancement, everybody does. And so that focusing on the fact that when you think about housing disparities and you think about who's most disadvantaged in the housing space, it is first and foremost Black people, certainly brown people next. And so I'm excited about the fact that we have an opportunity, policymakers at the local level and the state level, and hopefully to some degree at the federal level, have an opportunity to really walk through the door of this moment that we're in and to make a commitment like we haven't before to making sure that every single American citizen, in particular Black and brown people, have access to quality, safe, affordable housing. Because if we can do that, it is, I think, as the Representative Shalala said, it isn't the only thing, but it is, I like to say to my staff around here at Bedford City, it is the tail that's wagging the dog when it comes to the persistence of poverty and the disadvantages and disparities that folks experience here in Washington, D.C. If we could only fix one thing in this city, we would fix our housing crisis.
Great. Thanks so much, George. And I think you're right in thinking about then, right, the impact that having that safe, decent, affordable housing has, for all the folks that you're serving at your clinic. So thanks so much for that. I believe we do now have Pilar with us.
Thanks, Andy. I was waiting to be unmuted earlier, but I'm here now. And I work for the Housing Authority of the City of Austin, and I've been with them for over 20 years now, serving the most vulnerable population in Austin, most of which are African American, Hispanic, other types of minorities, and we certainly have been saddened, disgusted, and enraged by the recent happenings, but we also understand that those are just examples of many, many the systemic racism that exists in America. And unfortunately, it's taken some really gross examples for us and all America to wake up and take a part in trying to find a solution. But we as an organization have bolstered our diversity, equity, inclusion programs, and hopefully we can use the opportunities that we have to advance social justice in our city and within our organization. Our opportunities are within hiring, within promotions, procurement, and resident programming. This really confirms that we've been on the right track towards finding health partners that will provide better health access to quality health care for our residents. Because just like Congresswoman Shalala said, everything is connected. We've had great workforce development programs, youth education programs, and we always find that health has impacted the outcomes. No matter how much money we went through at the problem, if we don't address the health issues that our residents are facing and the disparities, then workforce development and youth education will not go as far as we need it to go. For example, many of our residents are able to get job placement, job coaching through our programs, but then once somebody gets very sick or they get sick in their family, then they have to stop working and care for the ill member of the family or themselves. So health is definitely now at the forefront at the Housing Authority, and we are very happy to have the opportunity to have to assist our residents, not only with health programming and education, but with encouraging them to have their voices heard, encouraging them to get out of their communities. For a long time, our residents have isolated themselves within their public housing properties. They don't go outside their community. They trust the people they live next to. They don't trust the people that live in the new gentrified apartment complexes right next to them. So we are encouraging our residents to get out there, be a part of the solution, understand that they're important and they can make a difference through civic engagement. So we are looking forward to the new energy that that is now here in America because of what has happened. We'll take full advantage of that to ensure that all of us participate within our housing authority. And I look forward to our discussion.
Great. Thank you, Pilar, so much. And I really appreciate Congresswoman Shalala and also George and Pilar, kind of your comments and thoughts as we kind of think about our current situation and the highlighting of the horrendous institutional racism and injustice that right is actually at the core of all of this, right, is fixing and addressing those issues. If we don't do that, right, we will never get there on some of these other kind of operational and other issues that we're going to talk about some. But so really, really appreciate that. Representative Shalala, I'm wondering if kind of given your long history, and I would say that the diversity of roles that you've played in terms of being a member of Congress, being on the front lines, being at HUD, being secretary at HHS, I'm wondering kind of even from a larger perspective, if you could share with us as we in kind of the healthcare space try to partner with public housing agencies and other housing partners, and they try to partner with us, and you've done a lot of this work in your career. So we'd love any thoughts you have on kind of common themes or tried and true things that have worked or haven't worked as we look to try to create these kind of cross-sector partnerships between housing and healthcare and childcare and education, et cetera.
Can you hear me?
Yes,
we can hear you.
We can, Representative. Thank you.
Thank you. You know, the federal government, the national government is so fragmented in terms of how it deals with these issues, in terms of different agencies in different places. But Congress is also fragmented because we have a committee system that makes it, I mean, SNAP is over in agriculture. Head Start is in HHS. Education is in the Department of Education. Housing, obviously, is at HUD. And so the way to integrate this is at the local level, is by people building relationships and figuring out how to get a seamless, focusing on the customer is the client. The customer are the people that are living in public housing, and how can you pull things together? So I'm not completely abdicating my responsibility, but I think the best we can do is to send resources down and to urge you to do what you're doing, and that is to reach across and work it out at the local level. And I'm being very candid for someone that has worked at the federal level for a long time. One of the things that COVID-19 has done for me is that I'm more of a local official than I've ever been, because people go to the federal office and ask a lot of questions. But whether it's my Zoom calls or in 2 hours, I'm going to deliver meals to the heroes in one of our hospitals, the nurses. But I'm working with people that are on the ground now in a way I haven't before. Now, I have in my whole career, obviously, talked to people, but I'm getting a much better, I'm still learning a much better sense of how difficult it is to integrate these programs. But all of my experience is it has to be done at the local level. I'm just not one of those fancy Fed types that thinks that we can do it. We can do it at the federal level, even though after my terrible HUD experience getting blown off by the HHS people, I demanded the HHS people, when I got to be secretary, run over to HUD and see what they could do.
Thank you. And I will just say, I think some of that work that you did in the Clinton administration has had a lot of tails to it in a positive way. We have a long way to go for sure, but I think there's certainly more of those conversations across HUD and HHS that I know some that were a part of as well. So it did not go, it served a larger purpose even after maybe you left. So thank you for that. And I think the other thing I would just want to highlight, you pointed to the relationships piece, and that's just the interpersonal, right? One-to-one and then organization to organization. And I don't know if you have anything more to share on that, but I will just tell you, I feel like in our partnerships with our Medicaid health plans and working with the great public housing agencies, it's actually having those conversations, right? I think about in Seattle where the CEO of our health plan, now knows and talks to the CEO of the King County and Seattle housing authorities. They know each other. They understand the overlap in the population, and they're thinking about ways that they can work together. So I really appreciate you raising that point.
One of the things that happened in the Clinton administration, I think with one exception, we all knew each other at the cabinet level. So Henry Cisneros, who ran HUD at the time, was one of my oldest friends. And we had been on panels together. We had been on boards together. We were on the Carnegie board together. We had been on housing boards together. So the relationships at the cabinet level were seamless because we all knew each other over the years in various places. And that made a huge difference in us trying to work together, at least at that level, and us seeing the integration that needed to take place. But at the end of the day, it really is those relationships at the local level. And Michael will tell you that very precisely.
Yeah. And Representative, is it possible that we could have you for a few more minutes for one more question before you get to your next responsibility?
Sure. I'm going to stay until 12:45, so I'm fine. So let everybody else talk.
Excellent. All right. Well, we will do that. I wanted to be mindful of your time and just really appreciate.
No, I like learning, so I'm very anxious to hear from everybody else.
If you don't mind, we're going to ask you one more question, and then we'll let you learn after that. How's that for a deal?
Fair.
Okay. I think another question, I think as we think about, in particular with COVID-19, I think it really highlights a lot of the issues for seniors, and in particular, extremely low-income seniors and people living in nursing care facilities, but also large numbers of people living in public housing and senior developments, that are very, very sick and vulnerable. And so I'm wondering if you could share with us from your perspective, kind of how you think about that, or as we think about kind of how COVID has highlighted these issues, kind of ideas and strategies that you would, or recommendations that you would share for all of us.
Well, some of them we've implemented here in Miami-Dade County. And that is, anyone can call 311 that's over 60 and get meals delivered to them wherever they are in the county. So that's been very important. Targeting nursing homes for and their employees has been extremely important in managing the disease. We still are not testing everybody in a nursing home in this country, and I've been on the warpath with CMS about this and with local and state governments. We need to test everybody in nursing homes, but more importantly, just as important, their employees. Many of the employees are low income because we don't pay very much for nursing homes. Because they're mostly Medicaid, as you well know. And they work in more than one place. And so testing employees becomes very important. The administration was deinstitutionalizing, deregulating nursing homes when they came in. Last July, they introduced a regulation to tell nursing homes they didn't have to have a full-time person worrying about infectious diseases. Can you imagine? Now they've had to go back and say, yeah, that's a priority. But we're still, half of our deaths in this state are in nursing homes. And so we still, every place in the country, we need to focus our resources and our testing in particular. And we've made testing free, and we're about to make treatment free as well, but basically we've given the hospitals a lot of money to take care of treatment. But in public housing, where there are seniors, our fire departments are sending people to test people when they call 311. Seniors, homebound, anyone that's homebound needs to be tested, and there needs to be a system in every community to do those tests. And here in Miami-Dade, and Michael might want to jump in, here in Miami-Dade, we're actually sending fire officers to test people in almost every community here. So we're doing a number of things, but the focus on nursing homes, they're petri dishes. But it's not just nursing homes. It's jails, it's detention centers, it's prisons, wherever we have people living in close quarters. That's also true of public housing. And we've got to make testing more convenient, whether it's the local drugstores or setting up mobile units. And I think, particularly as people go back to work, who are the people that work in restaurants? They're not middle class or upper class people. They need an opportunity to be tested before they're pulled back into these jobs. And so I'm very concerned with the level of testing, the follow-up, the kind of sanitation things that we need to do. And everybody's running around talking about contact tracing. And as much as I think that has to be part of the strategy, I'm much more worried about making sure everybody is being tested, that they have proper PPE equipment for whatever job they have to go back to, because many of these jobs are inside someplace, and we have to combine those two. And I know all of you in public housing have real challenges in terms of sanitation and infectious disease. You've had them for some period of time, but we've allocated the money in Congress over and over again, and we'll keep doing it. But local communities and states have to really take hold. You always target where your most vulnerable people are, in my judgment. I think it's immoral to do anything else. So that's my answer.
Thank you so much. And I want to get back to our very esteemed panel in 1 second, but since you alluded to that, Michael, I'd welcome you if you want to just make a brief comment about Miami, and then Pilar and George, we're going to spend the rest of our time with you all talking. So, and then have some Q&A. But Michael, if you have a quick comment, we welcome it. Maybe we'll come back to him. Pilar, if you don't mind, I'd like to turn to you next. And I'm wondering if you could talk a little bit about the experience of for you all as a housing authority, kind of in this partnership with us in our health plan, and how we're trying to create these partnerships with federally qualified health centers that are our providers and the like, and kind of what some of the challenges have been, and also what some of the positives and opportunities you've seen.
Sure, Andy. Well, I'll tell you that there are 5 key ingredients that housing authorities are going to need to advance their health and wellness programs. One is the will of the organization to bolster those programs, partnerships, as we're talking about, funding, a catalyst, somebody in your agency that is fully dedicated to advancing your health and wellness programs, and data to design programming based on the propensity of needs and what residents think they need. So let me speak to the partnerships. We have a partnership with UnitedHealthcare. Thank you, Andy, for that. It's been great. We have a partnership with community health centers here in Austin. Our community care is the largest community health center here in Texas. The partnership with them has been essential to open access to quality healthcare for our residents. For example, we're having community care reside at one of our RAD converted, newly constructed properties to provide medical and dental services on site for our residents. They've also conducted testing for the coronavirus on site at one of our properties that is dedicated for persons with disabilities and persons over 62 years old. Over 85 of our residents volunteered to be tested. 77 of those consented to share their results with us, the Housing Authority. That's going to be important so that we can help residents and the staff that are there know what precautions to take if there is a positive case. In addition, I was appointed by the taxing district to serve on Community Care's Board of Directors. Our chairman of our board has served on the taxing district Board of Trustees. So that brings firsthand knowledge back to the Housing Authority, and it brings firsthand knowledge back to that community care organization, so that we have the latest information about each other and what is available. Our partnership with UnitedHealthcare, we have found several ways that we can work together. One of the things that we did find is that housing authorities are going to need the infrastructure and expertise to implement programs. For example, we're going to need a partner to administer the billing to CMOs, to UnitedHealthcare. If that ever comes to fruition, if we can get CMOs to allow us, housing authorities, to bill for the services, health services we have, that can sustain our programs. But a housing authority doesn't have the infrastructure to do that billing. The other thing that we've learned is that we're going to need a partner that has the expertise to supervise and oversee our community health workers. We don't have the expertise to do that, and we shouldn't even try to do that. And we really don't have the extensive experience working with HIPAA-protected information. We conducted a very comprehensive needs assessment at 3 of our sites. Over 60% of our residents at those sites participated, but it took 45 minutes to 2 hours each to conduct those, because it was door to door in their units, and it was comprehensive. Now we have all this data about our residents and their health that we can't really share on a one-to-one at the Housing Authority. Only our staff that has had training with HIPAA can actually be viewing that information on a person-to-person level. So again, we're realizing that just like all our other programs, we are going to need, a catalyst, somebody at the agency that can advance the programs, but we're going to need partners to provide the programming, partners that have the expertise and the infrastructure. And so the other thing that we've learned from our partnership with UnitedHealthcare is that UnitedHealthcare has already been providing extensive services for people of low income that are on their rolls. And so our program offerings have on the surface looked very similar to what UnitedHealthcare has been doing. And so we're gonna have to prove up that our services and our program, boots on the ground at the Housing Authority, can actually result in better health outcomes in order to be funded. So that's one thing that we're working on.
Great, thank you very much. And I think I will just say and I'm going to get to you here in a second, George, but I think it's that note about the community health worker, I think, is so critical from where we sit at UnitedHealthcare. I'm sure some docs don't like me, but I always tell people that if you look across the bazillion people in our network, on the Medicaid side at least, the most important people by far are our community health workers. Absent them, people never get to see the doc or the specialist or anyone else. And so I think one of the things that we're looking to do is think about how can we have more and deploy our community health workers in a more strategic way. Sometimes they just get pulled in a billion directions for a lot of reasons, but trying to be more intentional about how we use them. George, I want to turn to you, please, and I'm wondering if you could just maybe share a little bit more about your agency, and then kind of locally how you have developed partnerships with housing agencies, and kind of, in your experience, kind of what worked and where did you have challenges and what have been the benefits of it?
Yes. First, I have to confess that I think we have a lot of work to do here in DC in general, at Bedford City probably in particular, when it comes to forging more formal partnerships. In a lot of ways, our partnerships have been with the housing councils and with tenants directly. So a lot of our work is about partnering with tenants in both private affordable housing developments and public affordable housing developments. And so we have a ton of experience with that. And a lot of it is around organizing for reforms that are needed, sometimes about housing, but just as often about some other socioeconomic challenge that the residents are experiencing. So I think that's a really important formula. In a lot of ways, Bread for the City has this really robust partnership with folks living in affordable housing. But I do think, as we were talking about earlier, I do think we have this moment in time when the partnerships that could happen between housing, the actual housing institutions, whether it be the housing authority in DC or the housing developments that they oversee, that there's a chance to really create new solutions, to really recommit. I mean, one of the things I like to say about housing in this city, and this is probably true about most urban areas, is that, you know, over the last decade, when some of the redevelopment / gentrification took place in the city, I was amazed at how quickly that housing was developed. I mean, like for me, and I say this to our policymakers all the time, is like, we don't have a problem developing quality housing. And we show that we can do it in months, you know, sometimes. The question is, who will we do it for? And I think that's one of the things that Bread for the City is really focused on right now, is how can we get the housing authority and private housing sources and the government, to be honest with you, in general here in our local government, to sort of acknowledge that it isn't a problem to build the housing. It's a problem if we're willing to build it for people with low incomes. And so I think that's a big piece that Bread for the City and the community health centers in our city, and we've got at least 8 of us who are part of a coalition at the DC Primary Care Association. In a lot of ways, we're really pushing for those kinds of reforms in our city to again, go back to what you said earlier, which is housing is health. You know, this city, our city spends about, according to our own sort of public health officers, we spend about $1 billion to $1.5 billion on care that is in the hospitals that is not necessary. In other words, what they call lane visits, low acuity, non-emergency visits. And if we could take that $1.5 billion and build housing, and I think our public health leaders know this in DC, that you would have far fewer people needing to show up in the hospital, because oftentimes people who are showing up in the hospitals are really housing insecure. It's really the stress that they experience from the housing. And so that's sort of the relationship, if you will, that Bread for the City has with the housing space here in DC. It's really trying to be a catalyst for, along with the other health centers, a catalyst for the kinds of reforms that could really solve so many of the challenges that people with low incomes experience, and the challenges, to be quite honest with you, that the public sector experiences, which is, how do we make the best use of the dollars we have in a way that sort of both solves our public health challenges, but also really fundamentally provides the kind of equity that people, again, particularly people of color in the city, but people in general deserve.
Great. Thanks so much, George. And I think I just wanted to note, I trying to follow the chat a little bit, and just want to note that that unequivocally, right? So we're talking a bit today in terms of some of our work at UnitedHealthcare. A whole host of this work happens, right, in what I would say kind of a plan agnostic way, right? And so other individuals who have other health plans are certainly accessing other services and other things. So just want to be clear that this isn't kind of like something exclusive for UnitedHealthcare, that, you know, a whole host of folks are getting the set of services and things that they need. And I'm quite sure that you're in the network of all the other, the other MCOs, appropriately so, in the District of Columbia. So I am recognizing Representative Shalala that I think we're going to lose you here in about 4 minutes. We did allow you to learn for about 15, but I did want to, before you do have to leave, I wanted to give you an opportunity to provide kind of a parting comment to our audience here.
Well, I've been looking at the chat room a little bit, and one of the issues was raised, isn't there something the federal government can do to incentivize departments to work together? And the answer is absolutely. And, you know, we've done it with grants and with a variety of different approaches, but I still am committed to doing things on the ground. That's my experience. The federal government is at its best when it just sends money. And with less strings, I would have to say, but with accountability. And I'm just going to keep working on this. And one of the things I can do as a member of Congress is, because I've run these agencies, I can answer the question, will that work or not? And so that's where I'm going to stay focused. And, you know, just using imagination during this pandemic, we're passing out SNAP applications at our libraries. And by the way, registration for voting at the same time. We had to pass out for a long time applications for unemployment there. The libraries aren't open. We're doing it outside the libraries because our system had totally broken down. Our goal is to shore up employment when people can't go to work, at least for a long enough period of time for the transition. But I'm very concerned to make sure we get people tested, particularly people that don't normally have clean access to the healthcare system, whether it's at their community health center or at a drugstore. We're starting to expand where you can get tested, because people should not go to work without being tested, and they need to get tested over and over again. This is not a test that hurts you. And so just for reassurance for their families. And that's the kind of thing that I'm going to be working on. Look, I'm always there for all of you, whatever I can do to be helpful. Michael has my numbers, and all of us are in Congress are working on these issues, and communicating with your member of Congress about what's really happening on the ground is absolutely critical. Thank you very much for the opportunity, and best wishes to everyone, and stay safe.
Thanks so much, Representative. Appreciate your leadership. Thanks for your time. All right. Pilar and George, I think I have one more question for you. And then Steve Lucas, if you don't mind, I'll turn it to you. I think you've been sorting through the chat some, and we can make sure that we get to more of the questions from folks in the audience. But George and Pilar, and either of you can start, but as you guys think about this work on the ground, and it could be something we share with the representative, or it could be something that you're pushing at the county level or the state level, but could you talk about a couple of the kind of policy changes or systems reforms that you think are needed in your community to better facilitate the integration of housing and healthcare for the people you serve?
I can start if that's okay. One of the things that COVID did for us is the governor was able to allow the FQHC to bill for telemedicine visits because of the state of emergency that was declared by the governor. He was allowed to do that. He had the power to do that. So that's one thing that we're going to need some policy changes in, is that we are able to bill for residents who have mobility problems and issues, that they can call their doctor through a video or a phone and have a visit with their doctor. So that's one of the things that we're seeing. The other thing that's happening now with COVID is that, again, some of our residents are not able to get themselves to testing sites. And there was nobody in Austin that could help us. Uber gave us codes, Lyft gave us codes for them to have free rides, but we don't want the residents exposing a driver. The driver doesn't want to be exposed. There's the bus system, the same thing. Do you really want somebody that has systems about to go get tested to get on a public bus? So there were just no real options. And so after speaking to several people here in the city, then the health centers, the FQHC, came out to our site. And they're also working on mailing tests out to people that can't get to testing sites, and so that they can mail them back. They think they're the first in the country in FQHC that's going to be able to do that. So just creative ways of ensuring that we can break the barriers of access, like those examples.
Great, thanks, and really great insights. Thanks, Pilar. And George.
So, I agree with those sort of near-term reforms very much. So, I mean, I think here in DC, this not only have we been aided by the telemedicine sort of accommodations, allowing us to bill for telephone, rather than just video has been really helpful because not everybody has video, of course, and so that's been a really important reform. There's some questions about how long that's going to stay in place, and so we're now pushing to sort of try to, extend that period when that's the case. But I want to go back to the thing I talked about earlier. Here in the district, one of the long-term reforms that hopefully, again, can be a part of what to do next in response of this time is that with that $1.5 billion that we spend at the hospital, that probably should be spent at worst in primary care settings, but at best, perhaps in other sort of social determinant spaces. One of the reasons that it's not happening in DC now is that those, 75% of those dollars are federal dollars, through Medicaid share, if you will, from the federal share to DC's 25%. And so what we hear from the local policymakers and local program heads is that even if they made those savings, the dollars would, in theory, have to go back to the feds, or we'd have to get permission. So I think sort of getting, creating an environment where at the federal level and the local level, there's this sort of agreement around the idea that not only do we want to save this money, not only want to sort of redirect people out of the hospital and have reasons for people to not go to the hospitals just because they're housing insecure or hungry, or combination of both, but that we need flexibility, waivers, if you will, that would allow us to use those savings quickly. I mean, instantly. I think what the emphasis should be on is immediately allowing new policies and practices around what to do with those, what potential savings from those settings could really impact exponentially what we can do to address, sort of the social determinants and fundamental challenges that people who access the healthcare system struggle with so much.
Great. George, thanks so much. And I'll say a couple of notes, and then I'm going to turn it to you, Steve. But I think, just from our perspective, from kind of the managed care perspective, 100% agree. And I can tell you, we're kind of currently working on a whole set of policy proposals that we're going to be trying to advance at the state level, and some with CMS, that will try to think about what are some of these things that we're doing now within this crisis that we're allowed to do, that honestly we ought to be able to keep doing, right, to better serve especially people who are really disconnected to care. So for us too, also a huge emphasis on telehealth, and also thinking about, for folks who are on the streets and other folks, like making sure that we can bill for services, even if it's outside the four walls, right? And all of those sorts of things. And one of the other things that we're looking at too is, I mentioned earlier with community health workers, we are just now formalizing a partnership with the National Association of Community Health Workers to jointly and with others kind of figure out what are some of those policy proposals that we put forth so that we can pay for community health workers with Medicaid dollars. In a lot of states, we or other MCOs need to use administrative dollars, not kind of Medicaid funding to pay for that, which is crazy, right? The community health workers are instrumental and integral to our efforts of trying to push for those kind of policy reforms as well. So thank you both very much. Steve, if you don't mind, I will turn it to you for questions that we have from the audience.
Great, thanks, Andy. So there's two to start us off, but I'm going to start with this question around funding and capacity. So in my role at CLPHA, I work with a lot of our PHAs who want to do this work or are doing this work. And sometimes the biggest challenge is going from, let's say 30% to 70%, like really sort of ramping up, scaling up activities and sustaining them. And a big barrier there can be funding or sustainable sources of funding. The question we received is to that effect: what are the major gaps that exist I would say within, especially George and Pilar, within your systems, what funding limits do you have? You know, and what would make the integration of housing, healthcare, you know, more incentivized and more sustainable. And Andy, I know, you know, state Medicaid plans, you're really at the mercy of the state Medicaid agency that's requiring plans to do certain things. So if you could maybe comment after Pilar and Jones, Pilar and George, about that, sort of what Medicaid plans and how they integrate SDOH into their work, which is kind of more of a regulatory question. So Pilar, do you want to start us?
Yeah, I can answer by giving you examples of what we've done with the first large grant that we've received for this. We received over $300,000 grant from a local foundation, St. David's Foundation. And with that, we were able to pay for 2 residents to be trained and become community health workers and for them to serve as community health workers. We paid for some of our catalysts. We've paid for the assessment. We've paid for a researcher and an expert to be on our team. And we've paid for data management by the Dell Medical School. So all of that was great. We were able to get the data that we needed, and the residents out there advocating for health and helping their fellow residents. Well, that ends on 12/31. So when it comes to funding, it needs to be sustainable. And I think St. David's Foundation has been very happy with what we've been able to accomplish, and I think they'll continue to fund some of that. But that was for 1 property. We have 18 properties. So in order to scale, we're going to need that every year times 18. So yes, community health workers are the key. They have been able to enter the units of our residents, build a relationship, build trust, and be able to assist them because of that. As they open up and as they don't have other networks, they can use a community health worker as somebody they can support that they can use. And I think that they will be the ones that will bring forth more long-lasting outcomes in health for our residents, but they're very expensive. The program is very expensive for you to have a community health worker that is providing that kind of intensive service provision, boots on the ground, visiting them multiple times, calling them multiple times, helping them connect to their doctor, helping them find a primary care physician, making sure that they're controlling their chronic disease. And so funding is just going to be, of course, essential. So we're working with Andy. Andy has visited us at least twice here in Austin. We're working on our partnership, and I hope that we're moving forward. Once Andy and UnitedHealthcare trailblaze through this new way of funding housing authorities, then other MCOs can join. But we're looking to Andy to be the trailblazer.
You know, as I was thinking about my answer, I was like, there are so many things, you know, it's a loaded question when you think about, well, what money do you need? The quick answer is a ton of it, of course, because there are so many challenges associated with both the affordable housing challenges, but also the access to healthcare challenges and the integration of those 2 things. So let me sort of rattle off the way it plays out in my head. You know, the one word I had promised myself I was going to say during this conversation, because I'm going to say it probably in every conversation I have from now, is reparations. And so, you know, reparations isn't necessarily the dirty word it was a decade ago or that kind of thing. But I think about reparations in terms of the way I heard, gosh, I'm blanking on his name, Ta-Nehisi Coates talk about it not long ago, which is that when you think about Affordable Care Act, and to some degree, when you think about the Affordable Care Act and how it benefits people of color so importantly, that's a form of reparations that works and that has some public support. And now that we're in this really moment of ours in our civil society, and again, the word reparations isn't nearly as toxic and political as it was some time ago. we should really start thinking about, and because people have such trouble giving cash to people with low incomes, we should start thinking about, well, let's sort of make sure that we reform our tax system when we become more progressive from a tax base, because we know that one of the challenges in our society is that there's too much concentration of wealth at the top end of the economic strata. So we're going to have to be more progressive there. And when we do that, if we want to avoid giving cash to people directly, then we should really think about a form of reparations that really sort of hyper funds these spaces, the housing spaces, the healthcare spaces, where those dollars would, and the childcare spaces, those dollars would effectively do what the people would do with it themselves if they were given it to them. Is that, what we find with the community members we serve, and there's always this concern about what they would do with money, but what people with low incomes would do if they had a greater economic floor, is that they would pay for childcare, they would pay for their housing, they would be able to pay for their medical expenses, that they would do what the rest of us do who are more privileged. And so I really think that, yes, money is needed. And I also should say that to the extent that we're talking about private dollars, foundations and the like, I think in terms of, whenever you get a foundation that does something, just like when a nonprofit is doing something in spaces to sort of try to move the needle on some social issue, it is always a pilot. We don't use that term, but none of us are scaled at the level that you could call it systemically addressing any particular issue. We're all just pilots, or as some people like to call it, aren't you all just Band-Aids? Well, to some degree, we probably are. And so even if a foundation like the Gates Foundation gave a lot of money, Gates isn't so big that it can solve all the social problems we have, but it could really, on a scale that would be really demonstrative of something that could move the needle, would be really impressive. And so, for instance, here in DC, I've been calling on policymakers to reach out to the largest foundations and say, there's some things we could do if you really sort of dug deep in your pockets and gave us money to deal with. Because right now, of course, the battle cry on the state and local levels is, we don't have the dollars. The market's tanked, revenue hasn't come in. And so we know that's going to be one of the pushes we get. Well, we've got to really sort of find other ways to get these dollars into our spaces so that we can, because again, this is the time to really make real improvements on these issues that have been troubling our society and our communities for decades.
Yeah, if not centuries. So yeah, thanks. And Steve, I'm realizing we're at time, Steve, so I'll be respectful. I think just in maybe 30 seconds, I would say certainly from the Medicaid managed care side, both from a number of states, and I can tell you within UnitedHealthcare, we are looking at a lot of different policy angles and policy reforms that we're advocating for states to request waivers from CMS so that we can finance what I maybe unartfully call kind of the glue, right? That all the services and supports that kind of tie these things together. Nobody wants to pay for those things, and yet they're the most critical part to actually having these things work together. And so we're working, like I think I mentioned earlier, on a number of efforts to finance and hire more community health workers to support with the host of this work. We're also pushing a whole host of states to do kind of what are called 1115 waivers to states to allow for Medicaid to pay for what we call tenancy support services. But that could be a whole set of things that's kind of the glue. And so I think those are, Steve, I think 2 examples I would provide of where we're trying to lean in very hard to figure out ways that we as managed care can pay for these services that are so badly needed.
So I just wanted to comment real quick, and for everybody who's in this session, we're going to talk about sort of how to get to the breakouts, and we've added passwords for extra security. But just before we wrap up this panel, I just wanted to note all 3 answers, I think, really point out how complicated funding as a concept can also be. George, I think you hit it on the head. It's like we can talk about gaps within existing organizations. We can talk about those things, but also when we're talking about funding gaps, we're talking about wealth gaps. We're talking about lots and lots of money. And to what Andy's talking about in terms of regulation and Representative Shalala, thinking big, right? Like we can do things at the federal level. We can take action at the state level. It takes leadership, but if there is will, there's a way. And I think we also need to, recognize that within the housing space too. I mean, if we believe that these things are, important to what housing authorities are tasked with doing or building those connections. I'm a little biased because of where I work and who I work with, but I really think that HUD and other federal agencies need to work together and identify what are these incentive structures, what is going to be a sustainable source of funding. To Pilar's point, I mean, foundations are there to germinate ideas and to sustain maybe shorter term, even midterm projects. But if we're talking about a sustained role that we want these organizations to play, it's really critical that we're advocating too and together. If Andy walks in the room to a housing advocacy table, or if we're going to health decision makers as housing advocates, that's really powerful. And so that's, to me, that's my takeaway from this, is like we do need to remain thinking bigger when it comes to these things as well. All right, well, I just want to thank the panel. Normally you get thunderous applause in person, but I just want to thank you all for your time and joining us and bearing with some of those bumps in the road, but I'm so pleased that we had you all. Abra, I'm going to turn it over to you to talk about next steps and getting people to breakouts. We will have a short break here coming up, so please stretch your legs, go outside, grab a snack, whatever you need to do. Abra, I'll hand it to you.
Thank you so much, and we will see you in the breakout sessions.